So this is about antibiotic-induced, non-allergic serious adverse reactions. That's the shortest I can make it. So primary care doctors and emergency physicians in particular are big users of antibiotics. We like them, our patients like them, everybody, it's good, they're cheap, expectations. But I think there are some things that we generally, problems that we never even consider when we give out antibiotics that I think are worthy of some consideration. Particularly from, the consequences of these problems are substantially higher than most of the issues that we're allergic. You get an allergy, you get a rash, you get vaginitis, you get diarrhea, you get C. diff, and all that stuff is, everybody knows that stuff. But here's some things that you should consider that are infrequently considered, like the fact that certain antibiotics have been strongly associated with production of cardiac arrhythmias. I don't know if you're familiar with this thing. This is erythromycin, the macrolides, that family of antibiotics, and all of its cousins, the clarithromycin and those jobbers. These drugs inhibit the P450 pathway, and so that anything that is metabolized by the P450 pathway has an opportunity to go up. Some of the things that go up, it's probably no big deal. Other things that go up is clearly a big deal. The list is there of some of the medicines that will go up in their blood levels when you give an antibiotic of the macrolide family. Quinidine, I don't think people use that. The zopramide, which is norpride, people don't use that. But look at this digoxin. Now, digoxin has fallen out of favor. There's no question about that. But look at this compelling data, abstract number 6. So this paper by Gerlink cites an odds ratio of admission for dig toxicity ranging from almost 12 times greater within 1 week of starting clarithromycin. You put this person on, and the likelihood of them getting admitted for dig toxicity goes up 12-fold within 1 week. Nobody would have ever considered that. And within 8-fold within 3 weeks of starting somebody on a clarithromycin. This relationship is compelling. And we often used to see patients who were dig toxic and you didn't know why and scratch your head. Well, this relationship is real. Other drugs that are listed there, omeprazole, ergotamine, acute ergate toxicity has been associated with the use of the macrolides as well. Sildenafil, what is that? That's Viagra. Well, that's the more the better of that. That's not bad. Benzos and statins. Statins are, everybody's taking statins to drive their cholesterol down. Well, this has been associated with increasing the level of statins to the point that rhabdomyolysis has been associated. So those are some of the issues with their inhibition of the P450 pathway. But independent of that, they have been associated with causing arrhythmias for other mechanisms which are unclear. So the issue here would be there are certain people who are prone to arrhythmias, and maybe it should be a good idea for you to be careful about giving out these drugs to that subset. What is that subset in particular? Patients on congestive heart failure. Because they have a high incidence of arrhythmias, they have a high incidence of sudden death. You call it bronchitis, and you treat the bronchitis, and a week later they die. Nobody's going to connect the dots to you, but the fact is maybe you had something to do with it. Plus the other thing is that people believe that these viral illnesses are stressors, and there's an association, but are they stressors associated with myocardial stress, ischemia, heart attacks, antibiotics? There's this whole conglomerate of kinds of things that should be considered. Now, there's no black box around the macrolides about cardiac arrhythmias or not, but I think that these papers are pretty convincing. Look at number 1, New England Journal, 5-fold incidence of death, 3 deaths per 194 person years. 3 deaths per 194 person years is not, that's a fair number of deaths with an association with some of these drug interactions. The other drug that is in this category of arrhythmias is the fluoroquinolones. Not well known, but it has clearly been associated. Causality, randomized double-blind trial, no. Associations, absolutely. And there are people who are maybe more prone to these, like the people who have pre-existing prolonged QT intervals, left ventricular dysfunction, low K and low MAG. Low K and low MAG. So a lot of the CHFers, low K, low MAG, if they're taking diuretics, they're all taking 4 pounds of Lasix, and that depletes you of your K, depletes you of your MAG, and so it's kind of like a bad situation. And then in the old days, you were taking diuretics and digoxin. So you're taking a K depleter, MAG depleter, and you're taking a drug which basically has been associated with arrhythmias on top of it. So there's a long list of things that predispose to fluoroquinolone-induced arrhythmias, which I won't read to you because I think it's just enumerated in your book about these folks. Well, how many people basically are going to be taking drugs that may do something to their QT interval? So the authors of that paper note that it's relatively common. About 10% of outpatients in one study of patients filled prescriptions for multiple drugs that concomitantly could result in QT prolongation. So it wouldn't be that unusual because most of these people are older folks taking drugs that can be associated with this issue. And finally, number 3 is this Italian analysis indicated a statistically significant association. They used 3 large databases in Italy of what the people were getting and what they developed. And when they looked at these 3 large databases, there was a statistically significant association with at least one of the databases between ventricular arrhythmias and sudden death and use of macrolides or fluoroquinolones. So I think it's probably good to know because there are other options for you if you want to treat the bronchitis or whatever it is. These drugs are commonly used, but maybe it would make sense to use something else in these papers who are people who may be prone to this. Next thing is tendinopathies with fluoroquinolones. Now there's a black box as of, I think, July, black box against fluoroquinolones with regard to the tendinopathies. It's really interesting how this has evolved and what kind of pressure was put on the FDA to make this black box. But this has been in a known association for a long, long time, and it's really fairly straightforward. Paper number 4 there and 5 deal with this topic. The first paper looked at a large database and determined that the odds ratio for Achilles tendon rupture was 4 times greater with current quinolone use, 2.5 times greater with exposure within 6 months. So this is a long-lasting potential, and 1.4 times greater with more remote exposure. So this appears to be real. It appears to be dose-related and age-related. The older you are, the more likely you are to get this complication. So the odds ratio for a tendon rupture for those between the ages of 60 and 79 is 6.5 times greater than the population at large. And for older people, older than 79, 20 times greater likelihood of a tendon rupture, 20 times greater Achilles tendon rupture when you give out fluoroquinolones for a respiratory infection in that older person who you're sending home. So, and one of the problems is there's this black box now. So they're going to say, doctor, look at what happened to poor Mr. Jones. Was there no other options for you to give some antibiotic for this viral illness in the first place to Mr. Jones? And so, and if you go onto the internet and put in tendons, fluoroquinolone lawsuits, there's at least 15 sites telling you, we'll sue for you if you get into this problem. Trust me, just when you go back, look at the internet. Now, have there been any lawsuits that we know about? Well, we do a thing called a Risk Management Monthly, and Dave Talon, who's an emergency physician, internal infectious disease specialist, probably the most well-known doctor in doing internal medicine, infectious disease and emergency medicine. He's involved in all of the lawsuits that relate to infectious diseases. He's either for you or against you in these lawsuits. So we interviewed him about 2 weeks ago, and I said, Dave, you see any of these lawsuits? And he said, no, I haven't seen any. But that doesn't mean that they're not in the pipeline. When you look at what's on the internet, and there's a black box that says don't do it or be aware of this. And in fact, pharmacists, when they give out a prescription for fluoroquinolone, are mandated to give out a fact sheet approved by the FDA warning people of this consequence. So if your tendons start bothering or hurting, those kinds of things, stop the antibiotic. And so this is kind of like happening in the background, and we're just kind of writing this stuff like, no, keep on writing, you know. And I think that it's going to be difficult to defend you when there is this rupture, because there are certainly other options to use in virtually every infection that you could think of. So I can't think, what is going to be the defense? Could you have used another antibiotic, doctor, if you're familiar with the black box? Yes and yes? Right, write the check, write the check. So I would have thought, frankly, that there would be a lot of these lawsuits. They seem to be a slam dunk kind of thing. Is it the standard of care to give antibiotics for bronchitis? Yes, it is. So that's not off the table. But the choice of antibiotic, doctor, we're concerned about, the black box.
In the operating room, we've seen numerous of these come through.
Oh, you've seen numerous tendons? Yeah. But they haven't, this is a compensatable injury.
And we do have one guy who was going to sue.
Did you hear our anesthesia? He said that they've seen a bunch of these cases.
I'm probably once every 2 months.
Once every 2 months. And say, oh, it's just bad luck. You know, you're old, you know.
Not in the elderly. We're talking 30, 40, 50s.
I got to think that this is a great opportunity for the lawyers and the patients to generate some cash.
So is your opinion that they're going to take the quinolones off the market?
No, I don't think they're going to take them off, but there's an alternative. And as long as you basically say, we must use this drug, and you won't be able to defend that, because you're going to give it for bronchitis anyway, so you won't be able to defend it. The box is there, the consequences are there. You know, I don't understand it. I've been concerned about this for, you know, a while, and we haven't heard anything, but here we go. We get the cases, the real cases, putting this stuff back together. Number 5 is a paper on the same topic, a review of 98 cases of quinolone-associated tendon injury. They made the following observations. 90% of the injuries involved the Achilles tendon. Rupture was reported in 40%. Huge, huge. When you think of Achilles tendon, this thing's as big as your little finger, and that thing broke. Male predominance, 2-to-1 male predominance, predisposing factors, steroid use, renal dysfunction, rheumatic diseases, diabetes, hyperparathyroidism, you know, but maybe, yes, they may be predisposers, but everybody apparently is at some risk in this. So this black box came up in July. History of it is really pretty interesting about how the FDA was really pushed by this public, I forget the name of I think it might have been detailed in your book a little bit about the history. The number of ruptures, I don't know the date of how current this is. 262 tendon ruptures have been reported to the FDA, 259 cases of tendinitis, 274 of tendon injuries, whatever that is. Levaquin was responsible for 60% of them. That's because everybody uses Levaquin for everything. So that's at the top of the list. Cipro was responsible for 1/4. So Cipro is being used for the traveler's diarrhea and the urinary infections, while the paper that we said is consider using nitrofurantoin, our old friend, 3% resistance rate now. So it also mentions there this business, the pharmacy mandate to give these people the instructions. So I would be very cautious about doing that. It's a crapshoot. It's Russian roulette. You might just be. Then there's this other thing about fluoroquinolones. I really thought, while I was researching this, came up with something new here. There's a class action lawsuit was generated in Italy about something that they call fluoroquinolone toxicity. This is a neuropsychiatric effect from this drug: tremor, confusion, anxiety, insomnia, agitation, and in severe cases, psychosis have been reported in a class action lawsuit. Moxifloxacin, this is a class effect, but some are worse than others, depending on what you're looking at. So it's all of the quinolones. I don't know why they just call them the fluoroquinolones. The quinolones are the family. Then we had the fluoroquinolones, and then we had the respiratory fluoroquinolones as subsets. So this is just a word to the wise. I think you got to back off the willy-nilly prescribing of this stuff, because these things, somebody's going to get in trouble. Now, you probably didn't. Any of you know of any of your colleagues who've gotten into any problem with this, or a complaint to the hospital or something? No. Okay.
My colleague ruptured his Achilles.
Who's that?
He ruptured his own Achilles.
He ruptured his own because he self-prescribed antibiotic for himself because he had bronchitis, right? It's justice. He won't be doing that, but that's a hard way to get people to change their practice.
For writing a prescription. I mean, a lot of this is, I mean, not just our prescribing, but what about, in some of the protocols for our hospital, Avalots is.
Oh, right.
You got to write for it. It's like they were in the hospital.
Well, the thing about it is this black box is new. It's probably time to look at the protocols, because basically for community-acquired pneumonia, you got a choice of Levaquin, or then you had, which is you needed only to take one of those suckers, no one pill kind of thing, or one shot. And then you had the azithromycin Rocephin combination, which was a two-jobber. So everybody kind of went to Levaquin kind of thing. Well, the azithromycin will stop your heart, but your tendons will be intact, and the other one is going to. And so maybe it's a time to reconsider, because I think the Pharmacy and Therapeutics Committee of all of the hospitals basically have some obligations to the patients and the medical staff to say, listen, this is something new that's come out. Are there some alternatives here? Because there are alternatives, even for community-acquired pneumonia. One of the really nicest things about Levaquin is that the blood levels for Levaquin are the same orally as they are IV. It's a well-kept secret. The idea was that you're going to come into the hospital with pneumonia because we have to give you these parenteral antibiotics. You go to the PDR, and there's a little graph in there that shows blood levels by mouth and by IV. They're the same. The pill has to dissolve, but after that, it's the same. You don't need to get IV Levaquin, and that's why so many people, when they had to try to beat this 4-hour thing on pneumonia, they would have like a bowl of M&Ms. Here's your Levaquin, pop one of these babies out in triage. They had a fever and cough. So they were all getting their 4-hour limits. Of course, they were giving this stuff out to people who didn't need it, but that was one of the tricks, because you didn't really need to give it parenterally, and most people thought you did. Got to wait for the X-ray. The X-ray is getting delayed. We missed our 4-hour, and the hospital goes nuts when you miss those time frames, because you're being compared with everybody else. So I think those of you who are on the PT committee might want to bring this up. What are we going to do about this? I don't think sticking your head in the sand. This is not going to get any better. This is just going to get worse and worse and worse. And I bet you next year there will be cases involving emergency physicians getting sued over this, because it sounds like an easy win. The next issues are, I think, also very important. This is about antibiotics and warfarin levels. So there's a big push in primary care to get all the atrial fibrillation patients to be taking warfarin to prevent their strokes. And the issue has been underutilization of warfarin, and so everybody's kind of trying to ascertain, should these people? Yes, they should. More warfarin's being given out, and we see in the ER all the warfarin problems. We see all of these hemorrhages, all of these things, and they come in and the INR is 6. How did it get to be 6? It was 2 last week, and now it's 6. They said, well, what did you eat, a rutabaga or something like that? Because warfarin there's a lot of things that can change your levels with that drug. One of the things that emergency physicians and primary care physicians need to be aware of is the effect of antibiotics on warfarin and INR levels. This data is compelling. Paper number 6, small numbers but dramatic results. INRs increase within days by a mean of 0.5 with azithromycin, which took a third of the patients out of the therapeutic range, bumped them above the therapeutic range, just taking azithromycin if it didn't stop your heart. Levaquin, it raised the INR an average of 0.8 and took 39% of the people given it within days above the therapeutic range. But look at this one, Bactrim. Bactrim raised in this small study, but it's not the only one, we'll get some others, 1.8 the INR, with the average raise and the INR was 1.8. That's almost therapeutic right there, 1.8, almost. It took 69% of the people given Bactrim above the therapeutic range. This is huge. 38% of the people given Bactrim had an INR increase of at least 2, a 31% an INR of 5 or higher, and 13% had bleeding complications. Well, your own clinical practice says, all we see is what happens when we prescribe it. We don't see necessarily that they went to the family doctor and the gums are bleeding or something like that. Is this the only paper? No, it isn't. No, it isn't. Number 7, link bleeding episodes requiring hospitalization to the use of warfarin and antibiotics. So this is the subset where it was bad enough that they had to be hospitalized for a bleed related to warfarin. They looked at about 140,000 person years, looked at the bleeding episodes. A statistically significant increase was noted for 10 antibiotics. Now, the thing that's a little strange is their list of the worst antibiotics doesn't correspond with the list of the previous study, which is the worst. In their list, the risk was 3 to 5 times greater of getting a hospitalized bleed if you took doxycycline, amoxicillin, with or without clavulanic acid, Cipro, clotrimazole, which is Bactrim, which is the 1.8 in the study above, and azithromycin. 3 to 5 times greater risk of having a admittable bleed on warfarin if you're on those antibiotics. What about tetracycline? 9 times greater likelihood of having an admittable GI bleed. Cephridine, which we use like water, and neomycin. This is about killing the bacteria in your gut, which has something to do with the absorption of vitamin K, which has something to do with your clotting factors. And now without vitamin K, through the killing of the bacteria in your gut, your INR now goes up under the infant because you're taking this warfarin. Cephridine, that's Keflex, isn't it? We use that for every boil, every little skin thing. 43 times greater incidence of admittable GI bleeds, looking at a study of 1,800 GI bleeds and this relationship. Now, one of the things that would be nice to have known in this study is, what was the absolute number? Are we talking about 5? And so you increase the number by 43 times that, and now you have 200? Well, that's not inconsistent, considerate either. 43 times greater with cephridine. So we're using some of these drugs. I don't know what you're using for these skin infections. Well, we're all concerned this is MRSA. So for those, we're going to have to use Bactrim or something else. But you're not sure, so throw in a little cephridine. So a lot of people are on now 2 antibiotics, sterilizing basically their gut, and their INR comes in 6 or 7, and poor grandpa now has got a bleed in his head. Has anybody connected the dots to why this INR is so high now? You may have had something to do with it. These papers say this is not a rare, random event. It is predictable. It is predictable because of the mechanism. Kill the bacteria, screw up the vitamin K absorption, up goes the INR. So people are afraid of this drug, and I think that because they see the bouncing, and basically we're so addicted to antibiotics that we are probably disproportionately, responsible for some of this stuff. And I don't know whether people really, you don't hear people talking about this relationship. I don't know whether people are unaware of it or they're unaware of the magnitude of it, those kinds of things.
Hey, Rick, so what should we do? I mean, if you've got somebody who's on warfarin and who needs an antibiotic.
Well, we're going to talk about, I think in the next paper, we're going to talk about what to do. Should you prophylactically ask the primary care doctor, listen, we need to put him on antibiotics. This is a really bad case of bronchitis. And what if we back off a little bit on the warfarin dose, knowing that this is a kind of a predictable association, and that is addressed in paper 8, which is a new, relatively new paper. When did that paper come out, number 8? Is that a 2009 paper? 2008. Okay. Because of this, knowing of this relationship, they said, listen, let's compare reducing the warfarin dose, only a small amount, 10 to 20%, which is hardly anything. The mean baseline in these people was 2.5, which is a good number to be at. INR was rechecked after about 5 days. In some of the people, they left them alone, and the other people, they reduced the warfarin dose. They gave them Bactrim, which is in the first paper was the worst drug that you could give them. And those people got Bactrim. The mean INR was greater than 4 in 2 of 8 with dose reduction, but was above 4 in 8 of 9 getting their usual dose, and above 6 in 4 of 9. Now the numbers are small, but the numbers are compelling. If we backed off on the dose, the INR was still greater than 4 in 2 of 8. If you didn't back off on the dose, the INR was above 4 in 8 of 9, and above 6 in 4 of those 9. You don't want to be an INR above 6. You don't want that. In Levaquin, it was above 4 in 0 of 10 who got the reduced dose of warfarin, versus it was above 4 in 5 of 13 who took the usual dose. But here's on the downside. The INR was subtherapeutic in 4 of 10 who got the down dose, who got modulated down. So they become subtherapeutic. So you're walking a really tightrope here. So the answer is, if you're going to give Bactrim, you should do this. The numbers were so compelling. Be more cautious with Levaquin was the distillate of this. Bactrim, bladder infections and all of these skin infections on warfarin. Talk to the family doctor. Doctor, can we reduce the dose a little bit? I'm concerned. Or actually, pick another drug, you know, on warfarin patients. You don't want to subject them to this. You will feel like a jerk if they have a bleed because it was certainly preventable. Next to last, did you know about this thing about sulfonamides antibiotics? This is the Bactrims again, inducing hypoglycemia because it looks for all the world like a sulfonamide, looks like a sulfonylurea, and fools the pancreas, and the pancreas kicks out more insulin when you gave this Bactrim for this urine infection or this skin infection. So number 10 is this emulation thing based on a review of 4 large Canadian databases of people over the age of 65, an odds ratio of between 5 and 6.5 times greater for admission to the hospital for hypoglycemia in diabetics on glyburide within 3 weeks of starting a sulfonamide antibiotic. Interesting relationship. So I wasn't aware that it fools the sulfonamide antibiotic, fools the pancreas. This is a sulfonylurea, blood sugar goes down. So this is kind of certainly more sophisticated, I think, emergency medicine and primary care, but these consequences are substantial. So you can, and they're avoidable. There's also this thing about these fluoroquinolones doing weird things to your sugar. Sometimes it goes up, sometimes it goes down. They call it dysglycemia. The fluoroquinolone on the top of the list for that is a gadafloxacin, but it's, again, a class effect. And then lastly, this has changed over time. So how many of you advise women who are in the child producing years to go on to barrier contraceptives when you give them a broad spectrum antibiotic? How many of you do that? Come on. We're going to publish a study. Okay. So the idea here is that broad spectrum antibiotics, a large, you know, across the board kind of thing, decreases the effect of birth control pills, and you could then wind up getting somebody pregnant. And there was a successful lawsuit in the United States against the dentist for unlawful pregnancy, or whatever you would call that. He lost. The dentist lost. So that there's a cluster of you who do that. These papers say, is this relationship real? Because in the past, the PDR basically said, you got to do this. PDR doesn't say that anymore. PDR has got much more kind of wishy-washy about it. And there's a paper here that says, is this recommendation, well, first of all, paper 11 says British doctors ignored the recommendations, and this basically often didn't talk about this to their patients. But number 12 is a paper that debunks what they perceive to be this myth about oral contraceptives and failure of birth control pills. They went through the list, they went through the literature, and this is the paper that's going to come defend you when that person does get pregnant, because this paper says there's no relationship really, except for one antibiotic. And what is that one antibiotic? Rifampin. Rifampin has been shown, and that is not so questionable. That is shown. Other TB drugs have been shown to be too, but we would never be using rifampin except for this MRSA staph business. So now people are giving out this stuff to try to kind of purify your body of this MRSA staph, and there's no question that you should advise somebody who's on rifampin, a woman, to use barrier contraception, because that's not a non-negotiable. It's not, it could be maybe, we're not so sure. That one, nobody's going to come to your defense if somebody gets pregnant on that one. So there are some unusual antibiotic adverse reactions. I think all of them are very legitimate concerns for primarily emergency physicians and primary care physicians, given the large number of people who we see getting them and the large number of people we see on warfarin.